My name is Mustafa. I'm a clinical research fellow and a surgical registrar at the London Deanery. And thank you for giving me this opportunity to present our project entitled Language Analysis to Interpret and Act on Written Patient Experience Feedback. I thought I'd briefly mention some background around our work, particularly around FFT and the real-time nature of patient experience feedback. We know that over the last decade, there's been a steadily increasing focus on collecting patient experience in real time and using it to improve care delivery, again, in a more timely manner. We know that a real-time approach to collecting data is anticipated to increase the chance of feedback being put to effective use, as staff feel like they have a greater sense of ownership of the results. We know that in the NHS, the near real-time feedback is collected by the National Policy Directive, the Friends and Family Test, also known as the FFT. However, from our own experience, we have identified that the Trust prioritizes FFT scores and response rates, but these fail to drive the change that we would like. In addition to these like-at-scale scores, there's also a free text option. This enables organizations such as ours to identify the why behind the responses, providing a richer, more nuanced picture of patient experience. The FFT has gone through a development process, as you probably are all aware of. One area of focus is encouraging NHS providers and commissioners to actively generate insight from the free text portion of FFT feedback and use this to drive changes locally and in near real time. So at Imperial, we know that there is the ability to analyze and interpret this free text falls short due to the resource intensity required to manually extract crucial information. Consequently, patient-reported feedback fails to drive the change that has been anticipated. At Imperial, we found that staff surveys suggested that only 15% of staff agree that the organization acts on patients' free text concerns or patient narratives. From an operational perspective, it is frustrating as time is being invested with little return of insights to improve care. From a patient perspective, it is demoralizing as their input is going unheard and problems are persisting for others. It also raises an ethical dilemma. We're collecting this patient feedback but not addressing it. Therefore, a semi-structured process to identify rapidly and categorize comments from free text responses may overcome some of these barriers encountered with manual extraction and long processing times. Next slide, please. Natural language processing, on the other hand, can be used to transform previously unstructured text into a structured format, which is then available for further quantitative analysis. This has been done in hospitality industries such as Booking.com and TripAdvisor, and it improves customer experience and understands the market behavior. We conducted a pilot study at Imperial using the capabilities of natural language processing and machine learning on the FFT free text data. 10% of retrospective comments were manually coded into themes according to the NHS Patient Experience Framework, which you can see on the slide. It has 8 key themes, from respect for patient-centered values all the way down to access to care. We also manually coded each comment according to the sentiment, that is negative, neutral, or positive. And as part of the validation process, a patient experience lead and also a lay representative coded 5% of the comments to ensure inter-rater agreement was satisfactory. Next slide, please. We then went about using a NIME analytics platform, and this was used to explore the ability of supervised learning to produce meaningful insights. The reason we used NIME was because it's free and open source, therefore maintaining our aspiration to scale our project at other NHS trusts in the UK. Next slide, please. We use supervised learning to train 6 machine learning algorithms, and this flowchart demonstrates the total number of comments from January to July 2017, where we had over 60,000 retrospective comments. 10% of them were manually coded, and a further 5% were coded by a lay representative and a patient experience lead. We then trained different learners And the machine learning model with the highest accuracy was used to classify the comments with the theme and the sentiment to produce the final database in inpatient, A&E, outpatient, and maternity. Next slide, please. So the free text data that we've got, which has now been categorized into themes and sentiment from the language analysis and associated FFT parameters, was presented to the key stakeholders to develop a bespoke dashboard, as you can see on the screen. Patient experience dashboards, we know, provide innovative means for facilitating QI, and therefore this was one of the key steps to ensuring that we deliver on our timely responses. This was guided by co-design principles. Our two-stage approach illustrates a range of stakeholder engagement methods, dashboard prototypes, and design insights on meaningful dashboard content, format, and clinical use. Here, the dashboard displays the top 5 themes in descending order, with negative sentiment comments labeled as to improve, and the top 5 positive labeled as doing well. The size of the bubble demonstrates the number of comments in each theme. Staff can choose the ward on the left and select a date range, as well as select only comments relating to a particular theme. Feedback from the heuristic evaluation demonstrated that the appearance of the dashboard needed to be simple, and that it should not look like a major task to understand the features. This meant that the final dashboard was ultimately designed for use by all healthcare staff, as demonstrated by the high usability score. We then developed the next slide, please. We then used the dashboard to instigate some QI work locally. Comments were filtered down to 4 medical wards at Imperial from a period of February to mid-April 2019. As you can see on the left-hand side, the theme relating to transition and continuity in amber was identified as an area requiring improvement by the frontline staff and was selected. This filtered down comments only relating to transition and continuity from a negative sentiment. Comments were around efficiency of the discharge process, lack of communication by healthcare staff regarding information for the patients and carers, delays in acquiring medication from pharmacy, delays in arranging social services and community support, and poor documentation on the discharge letter. Similarly, we also filtered comments relating to physical comfort, as demonstrated on the right-hand side in the red bubble, and all the comments you can see below are pertinent only to physical comfort. We then used the bespoke QI framework, also known as Project on a Page, which I'll show you on the next few slides. And it had a SMART objective, which is specific, measurable, achievable, realistic, and timely. The objective was to improve patient experience of transitions of care and continuity, and using the NLP dashboard to generate small tests of change based on negative patient comments and suggestions for improvement by using PDSA cycles. An important result and advantage of our study here is the approach is that it draws together very large FFT data into thematically driven, simple visual display without loss of the nuances that other manually based methods can have. And it can still allow for exploration of the original free text comments below. Next slide, please. As described, we implemented a discharge checklist as part of making improvements in transition and continuity for inpatients. Utilizing a discharge checklist ensured that communication and information transfer was done effectively, where patients felt involved in their care and were informed of the outcome and stages of their discharge. Engaging patients early on would mitigate some of the risks associated with transition and continuity. We also did some further work by looking at themes relating to access to care and read comments around that theme in particular. We improved the signage, particularly in accident and emergency, as we're a central London hospital, and getting to different facilities and different appointments can be very difficult. We also improved physical comfort during the month of July all the way to September, which is the peak of summer, by looking at some of the comments around physical comfort in outpatients. We then had more magazines, more hydration stations, and TVs as well, particularly for outpatient departments. Next slide, please. We know that NLP is a business model or a business innovation that, like other forms of artificial intelligence, is disrupting industries. It offers technical efficiencies, as we have found, through cost savings that arise from a reduction in labor costs. Therefore, it can be delivered at relatively minimal expense at other healthcare providers and may even provide a cost saving depending on current local arrangements. This work, we found, reduced the staff time required to manually sift through patient feedback, also known as a cost shifting activity, and relocating staff time supporting QI projects from 15 minutes with our NLP and language analysis to 4 days when it was done manually. We also noted, and this is very important, that there was a weak correlation with the average sentiment and the FFT score. What this suggests is that the FFT score does not necessarily dictate the sentiment of the free text, further validating the use of patient narrative or patient free text in driving quality improvement. Next slide, please. We know that the challenges of processing and analyzing unstructured patient feedback are not unique to our organization. We are grateful to be shortlisted for this award to showcase our work and spread, scale, and embed patient comments using language analysis as a near real-time initiative. The impact of applying this approach at a national level will be significant. Thank you.